Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Aboelata from Roots Community Health Center, and my co-host today is Dr. Aisha Mays, Roots Director of Adolescent and School-Based Services, and we're reporting for the week of February 15th, 2021. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you the information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Please submit your questions in the comments, by direct message, or by email to admin@rootsclinic.org. Now, we know that even though the pandemic is worldwide, the effects are very different depending on where you are. So we are here to give you up-to-date information on Alameda County, Oakland, and East Oakland in particular. Alameda County now has over 78,000 cases and 1,121 COVID deaths. Daily cases continue to come down from our wintertime spike, which peaked in the first half of January. But in looking at our 14-day average currently, we continue to be higher than we were at our summertime spike. But certainly things seem to be headed in the right direction. And here you can see hospitalizations, including ICU hospitalizations, coming down. And although ICU hospitalizations are coming down, it is doing so much more slowly than overall hospitalizations and cases. And we know that ICU hospitalizations and deaths do lag behind cases. Now, we know that this virus has hit Oakland harder than the rest of the county, and it has hit East Oakland even harder, and this fact remains unchanged. When we look at positive tests, we see that even though the 94601 zip code has improved, we continue to see very high rates in the 94603 and 94621 zip codes, which have positivity rates of 14% each, which is quite high and sustained and is almost triple what we're seeing in the county overall, which is a positivity rate of 4.9%. These same zip codes are experiencing much higher case rates, or cases per 100,000. Case rates in these zip codes are about 12,000 per 100,000 residents compared to 4,700 in the county overall. And what's especially concerning about this is that we are seeing these high case rates despite the fact that testing in these areas is lower than in other areas of the county. So in order to truly capture the severity of cases within these zip codes, we need to increase our testing even more than we have in these neighborhoods. Now, today we are focusing on COVID-19 and children. In the early days of the pandemic, we really didn't think that COVID-19 affected children much at all. And as a result, the level of surveillance, including all the different dashboards that the government has put up and all of the different screening interventions, have to some extent left children out. And also, schools closed fairly early on, and most of our attention went, rightfully so, to the groups with the high fatality rates, which is our older adults. And so all of this to some extent has hampered a bit of what we understand with COVID and children compared to what we have learned about COVID in adults. Our understanding of COVID in children has evolved quite a bit since the beginning, but there's still a lot that we don't know. Let's start with what we are seeing at Roots testing site in East Oakland. So far, we've tested over 2,500 children 18 and under. This represents about 10% of those we've tested overall since April. And the positivity rate for our young people is 18%, which is significantly higher than what we've seen in our 19 and up age group, where it's about 11%. And we believe that this is simply because children are being brought in for testing when they've been exposed or when they have symptoms, rather than routine surveillance, as we've seen with a lot of our essential workers, for example. So we're very glad to see parents and young adults being vigilant about getting tested when they're exposed or they have symptoms. Out of the 460 positive children from our site, we asked them or their parents about symptoms in the weeks prior to their positive test, and here's what we found. Essentially, in the 0 to 12 age group, just a little over 50% have symptoms. When we get to the 13 to 18-year-old, it's significantly higher, and about three-quarters of that group had symptoms. And when we get to the adults, it's higher still, with over 85% having symptoms. Remember that in all of these age groups, there may be people who were pre symptomatic at the time that we spoke to them. In other words, they just had not started to develop symptoms yet. But still, this trend is significant in that the younger age groups are much more likely to not have any symptoms at all than what we're seeing with adults. And when we took a deeper dive into this data, it showed that the younger age groups, like 10 and under, were more likely to present with fever, while the older they get, the more likely they were to present with cough. One of the questions coming up a lot is, are children more likely to contract and spread COVID? And this actually turned out to be not that easy to answer currently. There are a number of studies attempting to quantify this, and unfortunately, so far we have conflicting results. But again, there are actually a number of studies that are ongoing at this time, so we expect to continue to learn more and more as the days go by. Part of the challenge is that it really takes a high level of testing, surveillance, as well as contact tracing in order to be able to really answer these questions of comparing how this virus behaves in children compared to adults. And we look at what has gone on with school reopenings across the world, we are often finding ourselves having to compare apples and oranges with very different levels of community transmission rates and very different guidelines within schools. So we don't have a great way to quantify all of this at this time. Here in the United States, we are not doing widespread surveillance of children, and contact tracing in general has not been adequate to answer these questions. According to the American Academy of Pediatrics, children make up a little over 12% of cases nationwide, but probably much like we've seen at our own testing site, children are more likely to be tested when they have known exposure or symptoms as opposed to any kind of routine surveillance that employers may require or that essential workers may choose to engage in. And so, as schools reopen and there is more testing surveillance, we will certainly be able to learn more about transmission from children. It's very difficult to compare youth and adult transmission in the United States, also because schools have been closed for the most part, and children have been sheltering indoors to a much larger extent than adults. The two studies that we found that used very thorough contact tracing, one from Wuhan and one from here in the United States, showed a very similar rate of transmission between children and adults. And this included a close examination of transmission within households. There's some evidence that very young children may spread it less efficiently than older children, and this may have to do with less forceful coughing and sneezing in younger children. Now, my co host, Dr. Mays, will provide additional information about young people and COVID 19.
Thank you, Dr. Noha. Hello, everyone, and thank you again for joining us. We know that many of you may continue to have questions about how COVID 19 can affect the children and young people in your lives, if children and adolescents are able to be vaccinated for COVID, and the safety of school reopening. Again, here's what we do know about COVID 19 as it applies to children and youth. Children and young people of all ages can contract and pass on the coronavirus. It is still true that if children and young people get COVID, they often have milder symptoms, which may be closer to a cold or a mild flu, or no symptoms at all. However, children and youth have become very sick with COVID and even died, especially infants under the age of 1 and children and youth who have underlying health conditions such as asthma, heart disease, sickle cell disease, or diabetes. Many of you have had questions specifically about some of the severe effects of COVID 19 on children and may have heard the term MIS-C, which stands for Multisystem Inflammatory Syndrome in Children. So here's what we're told from the Centers for Disease Control about MIS-C. MIS-C is a condition where different body parts can become inflamed, including the heart, lungs, kidney, brain, and intestine. Scientists do not yet know what causes MIS-C. However, we do know that many children with MIS-C had the virus that causes COVID-19 or had been around someone with COVID-19. Most cases have been seen in children ages 1 to 14, but we have also seen cases in youth up to the age of 20. MIS-C is very serious and can be deadly, but most children who were diagnosed with MIS-C got better with medical care. Here are common symptoms of MIS-C: fever, abdominal pain, vomiting, diarrhea, neck pain, rash, bloodshot eyes, and feeling extra tired. Contact your child's doctor, nurse, or clinic right away if your child is showing symptoms of MIS-C. And seek emergency care right away if your child shows any of these emergency warning signs of MIS-C, which include trouble breathing, pain or pressure in the chest that does not go away, new confusion, inability to wake up or stay awake, bluish lips or face, or severe abdominal pain. If your child experiences any of these symptoms, don't wait, but take them directly to the nearest emergency room for evaluation. Many of you have also had questions about whether children and youth can receive the COVID-19 vaccine. We currently have 2 FDA-approved vaccines in the United States, one made by Pfizer Pharmaceutical Company and the other made by Moderna Pharmaceutical Company. The Pfizer vaccine's initial clinical trials included younger individuals and is currently FDA approved for ages 16 and older, while the Moderna vaccine clinical trials included primarily older individuals. The Moderna vaccine is currently approved for ages 18 and older. Both companies have begun clinical trials for children as young as 12, so we do anticipate more information this year on vaccine safety and efficacy for younger children. And lastly, what to do about school reopening. As many of you know, Oakland Unified School District initially planned to reopen its schools this semester on January the 25th, but decided to continue virtual learning because of the continued rise of COVID-19 and the impact on many of the communities that their students live in. We have, however, seen that some private schools in Oakland have reopened, and some of you have questions on how to keep your children and households safe with your children returning to school. Here are the current safety recommendations from the California Department of Public Health for children returning to school. Number 1, test. It is recommended that children, students, and staff participating in in-person school engage in frequent COVID-19 testing. Number 2, masks. All students and staff will be required to wear masks throughout the in-person school day, with staff required to wear medical-grade masks. Contact tracing. Schools should work with local health departments to streamline access to contact tracing to provide timely communication for any COVID-19 positive individuals or their families. 4, vaccination. School staff are prioritized to receive the COVID-19 vaccine. In addition to these guidelines, some schools have implemented additional safety measures like reducing class sizes, grouping students into smaller instructional pods, and having hybrid in-person virtual learning instruction plans to limit the amount of in-person time that classes are together. All of these school safety measures continue to send the same message: to continue to mask, distance, avoid large groups, and utilize new resources that we have, like vaccination, to stop the spread of COVID-19. If you choose to have your child return to school, please remember these very important points. And now back to you, Dr. Noha.
Thank you for that, Dr. Mays. So, we have said that children infected with SARS-CoV-2 are less likely to develop severe illness compared with adults, but children are still at risk of developing severe illness and complications from COVID 19. 12% of cases are among children, but just 2% of hospitalizations and 1% of COVID deaths are in children. So, that is reassuring. However, weekly COVID 19 hospital surveillance data show that rates of hospitalization among children is increasing, particularly over the last 4 weeks. In fact, LA County recently reported a 35% increase in that inflammatory condition Dr. Mays spoke of, Miss C, just over the last couple of weeks. Overall, of children hospitalized with COVID 19 in the United States, about 1 in 3 were admitted to the ICU, and this is very similar to the rate among adults. This seems to indicate that once COVID 19 symptoms are bad enough to take one to the hospital, it can become rather severe in a significant number of cases in both children and adults. Also, for reasons that are unclear, about 1 in 3 COVID deaths in children in the United States occurred outside of the hospital setting. We're still learning more about why that may be. Now, what about the relationship between community and school transmission? There's been a lot of discussion about this. The basic bottom line is that if community transmission is high, then students and staff are more likely to come to school while infectious. And therefore, it just provides more opportunity and more likelihood that COVID 19 will be introduced to the school and potentially transmitted within the school. Obviously, those mitigation measures that Dr. May spoke of would be critical in determining just how widespread that could end up being. But if children are much less likely to get very ill or die from COVID 19, then what's the big concern about reopening schools? So, from a clinical and epidemiological perspective, there are a few things to consider. First, it's the adults. So, keeping schools closed is not necessarily to save children from dying. It's mainly to keep adults from dying. The adults who teach them, the adults who work at the schools, and the adults who live with and care for them in the community. An analysis done by Kaiser Family Foundation showed that in the United States, about 1 in 4 teachers were in a high risk category for doing poorly with COVID 19. And of course, this is referring to unvaccinated individuals. So, in the absence of the vaccine, an estimated 25%, and this equates to 1.5 million teachers, are at risk of doing poorly if they were to catch COVID. Next, and this is extremely important, particularly in light of community conditions that I spoke of earlier. And this is the number of children who live in the same household with our elders. 590,000 seniors live with school-aged children in the state of California alone. And here you can see by this map, only Hawaii has a higher percentage of children living with elders than does California. But this is 11% or 590,000 of our seniors 65 and up who live with a child in the state of California. And as you can also see, this is much more likely to be the case with households of color, with, for example, 19% of Asian Pacific Island and Native Hawaiian elders living with school aged children compared to 4% of white seniors. So, as we think about the vulnerability of our communities overall, we need to be thinking about the number of people at risk within our communities and within the students' households, particularly as it relates to unvaccinated seniors. And we know that due to poorer access and a variety of other factors, that in some of our communities, we will have a lower percentage of vaccinated individuals within students' homes. And this segues right into the second issue, which is that of disparities. We've already shown the disproportionate burden of cases in certain regions of our county. We also know that in those same neighborhoods, we are seeing racial and ethnic disparities in terms of both contracting and doing poorly with COVID. In fact, in Alameda County overall, those of Latino or Hispanic descent are contracting COVID at about double the rate of others. And African Americans are dying at about double the rate of others. And this is across the county of Alameda. And what might be most alarming as it relates to COVID disparities in children is the extreme disparity that we are seeing for severe illness and death with children. And these are disparities that we really do not understand. According to the CDC, of children getting Miss C, that inflammatory condition that can lead to severe illness, an alarming 70% are Black and Latino, and we really don't know why. And of children who die from COVID, although again, it's a very small number overall, and even more alarming, 78% are Black and Latino. And again, we really do not understand why. So, between disparities and community factors, these are all things that need to be considered. Now, what about children and the new variants? Well, unfortunately, there is preliminary evidence that the UK variant does infect children much more readily than the main COVID strain present in the United States at this time. And many experts believe that the UK strain will become the dominant strain here in the US in the coming months. So, this is something we will need to keep an eye on, particularly because a lot of the calculations that have been done on classroom sizes, air exchange, the size of classrooms, etc., were done based on the infectivity that we understand from our current strain. So we may again need to redo our math in light of new strains as those begin to become more dominant. And the last thing I'll talk about is the schools themselves. And when it comes to assessing for COVID readiness, I will say if you've seen one school, you've seen one school. There are extreme variations as it relates to the age and condition of our schools, as it relates to ventilation and air exchange, HVAC, and available space. The areas of greatest concern at the schools will likely be the same as workplaces, and those are the cafeterias and break rooms where masks come off. And particularly with young people, there will be socializing, they may get a little boisterous and increase the likelihood of transmission. As Dr. Mays mentioned, plans for testing, surveillance, contact tracing, and outbreak investigation will be absolutely critical. And we should all be especially concerned for unvaccinated teachers, school staff, and household members of students, particularly those with underlying conditions and those of advanced age. Of course, all of these considerations we reviewed today must be weighed against very complex considerations regarding children's fundamental right to an education. We know that there are challenges with distance learning, but we also know that many of our children are adapting and coping just like teachers and parents are doing. And I think that everyone who has survived thus far, our teachers, our parents, our students, all deserve to be proud of the tremendous adaptation and flexibility you have shown in doing your part to help mitigate this health crisis. That concludes today's People's Health Briefing. Thank you for joining us. Please tune in next Tuesday at 10 a.m. See you then.